Hello, welcome to the Doc Dave Show. Today on the show we've got Dr. Mark Vucak. Dr. Mark Vucak is a well-known, renowned plastic and reconstructive surgeon. Welcome, Dr. Vucak, to the show.
Thank you.
Thank you so much for taking the time. You are well-known in the city, possibly worldwide, countrywide. You are known for a good plastic surgeon. I've referred personally most of my patients to you with complicated like skin cancers and other things. Apart from skin cancers, you do also a variety of procedures, notably breast implants, or breast augmentation, or breast reconstruction. Could you just talk us through some of the things you do, other than those things I know?
Well, I've been in practice for about 30 years now, which is sort of have some broad experience. And I first came to North Queensland and we gathered 4 guys together, so we had quite a broad practice, and we practiced from Cairns down to Rockhampton,
Right.
and out to Mount Isa. So we do a broad spectrum of plastic surgery, both cosmetic and reconstructive.
Right.
And so we divide our practice up, and I'm more interested in aesthetic surgery, and I've been doing a lot of breast augmentation, facelifts and post-bariatric surgery over the years. Ian and I have operated on 69,000 patients now, so we have a fairly broad experience in all aspects of the specialty.
Yeah, that's good. That's good. And we just want to put a disclaimer straight up front here. Dr. Vucak is here in his own capacity. Is here to share his clinical experience regarding some of the things we're going to talk about, in particular breast implants and the controversial issue about linkage to cancer, which we're going to talk in more detail today. So he's here in his own capacity. He's not representing anybody. He's not representing any organization. Whatever he's asking to say is from his personal experience, clinical experience as a clinician. Is that okay?
That's right.
That's right. Right. So breast implants have been going on for quite some years now.
Yes.
And I think going back 1992, I was checking through the FDA approval of they call it saline-based or saline-filled implants. And then they approved the silicone-filled implants in 2006. And you have been involved through that transition yourself. I think you had a clinical experience in the USA at some point. Just talk us through the transition during that time.
The first breast implants were placed in the US in the late 70s and early 80s. And I really started my practice in around 1990. And by the time I came into practice, the liquid silicone, which was the original implant, had been phased out, and we started, when I was doing my fellowship in Atlanta, we started using saline implants. And in the US, saline implants were the predominant implants for many years, but when I came back to Australia, we were able to use cohesive silicone gel, which they weren't allowed to use in the US. So we were able to develop quite a big experience in cohesive gel, and I've put in more than 10,000 implants now. So we've used a whole spectrum of different type of implants. And so in Australia, we gathered a big experience of cohesive gel, where in the US they're still using saline implants. And only more recently, 2006, 2007, they were able to use silicone implants in the US.
That's right.
Under certain circumstances.
That's right. That's right. But the full approval of silicone-filled implants was in 2006.
In the US.
In the US, yeah, that's right. And at that stage, there was concerns regarding safety. And
well, initially, as with all medical products, there's a lot of investigations and tests done, and people assumed these implants to be safe. And in our early experience, everything seemed to be very safe. But as time progressed and experience became more clear, things started happening with breast implants.
That's right.
And there's a lot of different parties involved, all with their own interests. For example, the implant manufacturers, I'm sure, don't tell us all the information that we need to know as surgeons. And it's not until problems started arising with breast implants that we sat up and said, well, maybe we should be doing something about this.
That's right.
So there's been 2 sets of problems. One is a vague collection of symptoms people calling breast implant disease. 2018 at MD Anderson, they published an article with 100,000 women looking at breast implants, and they found that there was increased incidence of Sjogren's disease, dermatomyositis, melanoma, and rheumatoid arthritis. So there's a 2 to 8 times higher increased association. So it's not the breast implants are causative of these conditions, but there's an increased association.
Yes, yes.
So that's one group of problems, and a lot of patients come and see me who have vague symptoms of dry eyes and fatigue, hair loss, and autoimmune symptoms. And over the last 5 to 10 years, I've been gradually hearing this, but now people are coming to me every week, and we're doing a lot of breast implant removal. So in the early days, I was putting maybe 10 augments a week in, that would be normal, and now I'm putting 1 or 2 implants in and taking 5 or 6 implants out every week.
Right.
Or maybe 7 or 8 women are taking implants out every week. So the situation has changed a lot from augmentation to explantation.
Yes, yes, yes.
So that's one side of the coin, which is the breast implant disease. The other side, around 3 or 4 years ago, became evident there was a rare cancer associated with breast implants, and this is anaplastic large cell lymphoma.
Yeah.
So this is a very important disease process, and we've found that worldwide there's maybe 900 women with ALCL, 100 in Australia, and 9 people have died. So it's an important disease process. So there's 2 separate issues. One is the breast implant illness, which is very topical, and we always pay attention to it. And the other is this the other is anaplastic large cell lymphoma.
Yes.
So there's been a lot of work, especially in Australia, to look at the etiology of ALCL, and there's been good work done through the Australian Society of Aesthetic Plastic Surgery and guys in Sydney. And they've really found that the problem has arisen because on a smooth implant there's not many bacteria on the surface, but on a textured implant there may be up to 70 times more bacteria depending on the nature of the texturing. And with certain brands of implants, the texturing is called macro texturing, and it's very aggressive texturing. And the reason that people might use a smooth implant or might use a textured implant, with the smooth implant, in the US, 80% of implants are smooth and 20% are textured. In Australia, 80% are textured and 20% have been smooth. So there's been a strong push for textured implants in Australia, and I think that's why we've seen this disease process come to light, because there's been more textured implants per head of population and compared to the type of implant. So the reason that people have moved from smooth to textured implant is because around a smooth implant, when an implant goes into your body, a biofilm forms, which is a bacterial contamination of the implant, and that can cause a capsule, and capsule can give you a stuck-on, hard, artificial appearance. And it's thought by having a textured implant, because the little fronds on the surface of the implant, the capsule won't be perfectly smooth, it'll be more higgledy-piggledy like this, and maybe the capsular contraction would be less. And so the first implants that came out had minimally textured implants, and there wasn't enough difference between the smooth implant and the minimally textured implant to warrant going to the new implant. So then manufacturers started using macro textured, which are very deeply textured, and bacteria hide inside those texturing, and a chronic inflammation in the right person with in the right conditions can cause this cancer to form. So it's a combination of the host susceptibility and the type of implant.
That's right. So I mean, looking at the FDA, they started to recognize that anaplastic large cell lymphoma back in 2011. And the WHO is taken up on board 2016, which is 5 years later on. But the outcry from both bodies is that there is a lack of data worldwide in terms of reporting from the surgeons, or maybe surgical data, basically because of what you call patient confidentiality and other issues. So there's no free flow of data sharing that information. Therefore, there's no defined, let's say, percentage risk of the implants. I mean, they say there's high risk, but we can't come up with a figure to say, okay, 10% will get this large cell lymphoma. Was this
I think the Australians are taking quite a good lead in this, because we've got the breast implant register now, which has been established through Monash, and we're looking at all the implants that go in in Australia, and we can determine the rate of ALCL and the incidence. And so we do actually have some fairly accurate information on which particular implants can produce this. For example, it's my understanding that The polyurethane implants and Allergan biocell implants have a rate of around 2,300 to 2,500 incidents of developing ALCL.
Right.
Because if you use mentor textured implants, the risk looks to be around about 1 in 83,000. Right. And there's been no cases associated with smooth implants of ALCL.
Right.
And Motiva, which is a new company, which is very popular and is my favourite at the moment, also has had no association with ALCL. There's only been 2 cases where there's been somebody with a smooth implant who've had ALCL, and both those patients have had macro-textured implants before, which were taken out and smooth implants replaced. So there's been no case of primary smooth implants, to my knowledge, developing ALCL.
Yeah. So what's your take then on saline-based and the silicone-based? Which one do you prefer for, clinically yourself?
So whether it's saline or silicone, that has no bearing on the development of ALCL, because that's to do with the surface of the implant.
Yeah.
So in early practice, for the first 8 years, I could only use saline implants because there was a moratorium on until we could start using silicone implants. And so I've put in a lot of saline implants, and they've been quite durable, but they do have a valve, and they tend to leak through the valve.
Right.
But if they do leak, your body's going to pass that fluid out without any trouble. Whereas if you've got a silicone-based implant, and the implant ruptures, it's going to create a local inflammation, and that can go on to have further problems. But there's a balance with all these things, because saline implants feel a bit like a waterbed inside your body, because it's a crinkly feeling that's much more prone to rippling.
Yes.
When you put a saline implant in, say for example the volume of the implant is 300 cc, if you fill with 300 cc, the implant is always underinflated, appears underinflated and produce rippling. So, but if you fill that over, most people overfill that by 10 or 15 cc, maybe 20 cc. So if you take a 300 cc implant and fill it to 320 cc, that takes out the rippling. But what happens is that instead of having a nice formed implant, it turns it into a tight, hard, round ball. So a lot of women we see when they have a stuck-on tennis ball appearance have got overinflated saline implants with a capsular contracture. So they lose the natural implant shape and end up with a hard round tennis ball shape with a saline implant. So silicone implants, especially subpectoral, have a much more natural feel, and it's a softer implant. I think all implants have a lifespan, not like every medical device, pacemakers, hip replacements, and so I always tell my patients that breast implants are like motor cars, and it's after 10 or 15 years you might need to have a new car. And the same thing with breast implants, will probably need to be exchanged because eventually they're going to rupture. And it's always better to change the implant out if it's gel before it ruptures, because if it ruptures and you get silicone extravasation, it can be quite problematic. I've had many patients where they've had a rupture, and the rupture first is within the capsule. So around the implant, a biofilm forms and a fibrous sac called the capsule. So initially the implant ruptures into the capsule, but if the capsule breaks, the gel can get out into the tissue. I had one lady about 3 years ago where the gel came out, and eventually it eroded into a lung, and they needed to do a lobectomy to remove part of a lung. So silicone extravasation is quite a big deal. And there's a high incidence of lymph node involvement, and the lymph nodes can be quite swollen. And if the implant ruptures and gets into the breast tissue, this is particularly with the Solastic 1 and Solastic 2 implants, so the original dark horning implants, where the gel spread all through the tissues. It's very difficult to determine whether you've got breast cancer or not on palpation, because you have lumps through the tissue, which is actually silicone in the tissue rather than breast cancer. So it's always better to change implants before they rupture.
For the sake of the viewers, they may sound big jargon here. Dr. Vucak is a big jargon anyway, but I think it's important that we define what we're talking about here. We're talking about the lymphoma, which is a non-Hodgkin's T-cell lymphoma, which is an immune type of cancer we're talking about. This is different from breast cancer.
It's different from breast cancer.
It's not the same thing. It's lymphoma, and breast cancer is something else totally different.
That's right.
Right. I'll take you back to the 2016 World Health Organization recommendation that there must be free information between plastic surgeons and everybody to share and maybe do more research in this area. Is there any other research going on in Australia,
Yeah, I think Australia, most of the research for ALCL has been done at the moment. So this year I've been to the British Society meeting in October in London, and I was in Sweden at the meeting there in the middle of the year, and they're always asking for Australian researchers and professionals to contribute regarding ALCL to these meetings, because I think we're way ahead of everybody else, because most of the information has been collected by Australians so far.
Yes, yes. What, this story about the reformer has been in the news, in the media for a while now. Have you seen a deluge of customers or your patients coming back to say, giving you a phone call, no, I'm worried about this, can you take it off? How have they taken this, your patients?
Yeah, so I think social media is a very powerful thing, and there's a few things which are good about social media and a few things bad, because there can be a lot of paranoia. Yes. Because, for example, the risk of a woman having breast cancer, maybe 1:14 or 1:16, but the risk of getting anaplastic large cell lymphoma with, say, a mentor implant is 1:83,000. There's a lot of difference between 1:14 and 1:83,000. I don't see people rushing every day to have their breasts removed, when the incidence is much higher with breast cancer. The risk of breast cancer is so much higher. So I think people aren't necessarily too concerned about the whole ALCL problem on social media. The main emphasis has been towards the whole concept of breast implant disease and fatigue and what breast implants are doing to your body. And people that come and see me aren't concerned about ALCL, they're concerned about the whole concept of breast implant disease. We're particularly kind of concerned about having the ALCL, which is the cancer related to breast implants. If one breast was swollen, for example, or there was pain in one breast and the other breast was unchanged, or because if you have this particular tumour, the breast will fill up with fluid, and we will need to aspirate that, perform a capsulectomy, remove the implant and find out what's going on, because further treatment may be required. So we're particularly concerned about anybody with a textured implant, especially a macro-textured implant, and anybody with a swollen breast. The mean time from insertion to development of these symptoms is 8 years. So it's not something that happens on the first 3 to 4 years. By the time you get to 20 years, largely the situation. The mean is at 8 years. So that's a subgroup of people. So those people would come up just with a swollen breast, and they might need further investigation.
I suppose it's always difficult, when a lady or a woman comes for the first time around, wants breast done, augmentation, could be for reconstructive purposes, pick up for various reasons. To cancel them in terms of the breast implants, and now you've got all these side effects available, rheumatoid arthritis, you say, so Sjogren's and fatigue and all that stuff. Now we've got cancer now. To cancel them, to say, this may not happen. There's information available on FDA website. There's detailed information and leaflets for the patients and also for the health professionals. How do you cancel them? How do you reassure them coming for the first time? And already they've done all these social media chat, they've done all this Googling chat, and they come to you and say, okay, I still want to know more about this. And how do you cancel them?
Well, it's one of the hardest parts of surgical practice, because breast implants are a very emotive issue, and by the time people have decided that they want to have a breast augmentation, it's like having a new car. People rush in, they think this is fabulous. They don't know, or they do realise that it can have problems in 10 15 years' time, but not thinking about that. So it's very hard for people to take this in. And so a lot of, no matter what you tell people, they gloss over it and say, well, that can't happen to me. And then when it does happen to them, they say, well, you didn't tell me about that. So we encourage always people to have 2 consultations, so that they can get over the initial euphoria and get down to the syntax and find out what's important when they come into the consultation, so that they understand all the ins and outs of it, rather than just going forward without enough information. So they need 2 consultations beforehand, and we'll size them with the implant, we'll give them information, we'll talk to them, we'll show them photographs of what their appearances may be like. You can use photo imaging with Vector if you wanted to. It's mandatory now from the Australian TGA to give all patients written information about the ALCL problems, but not necessarily so about the breast implant disease.
Yes.
But we do include that. We give them written information,
Yes.
and we take them through that, and they're presented with it. And I also show patients these studies, which are showing documented evidence of these associations, and we try and be a bit more selective than some other people in that we don't necessarily operate on everybody.
Yes.
And people have to have a good understanding what let themselves in for, because all these surgeries, it's still a surgery. It's not just,
Yes.
it's like cardiac surgery or neurosurgery. It's a major surgery,
Yes.
but people gloss over that because it's easily popularised by social media, and they think there's nothing to it, and nothing can go wrong. There's a lot of things that can go wrong.
Yeah, there is. No, so you take the implant out. Let's say a lady comes, okay, take them off, doctor. They've been there for 8 years. I've heard what you say. Just take it out. What do you do with the space?
So it just depends on what the patient wants, and it depends on the shape of their breasts and their age and their requirements. Because people, if they come, they had the implants in when they're 25 and now they're 70, well, that's a very easy decision to make, because it's easy just to take the implant out.
Yeah.
But some people, even if you're elderly, you still want to maintain the shape, because when you take the implants out, all of a sudden you lose your identity, female identity, and it's very important to feel womanly still, and the breast implants do that for a lot of women. There's three options basically. One is just to take the implant out and leave it. The second is to take the implant out and fat graft the space. So what I mean by that is that we can take fat from the buttock or from the thigh or from the abdomen and take the implant out. Say it's a 300cc implant, and we could put that 300cc back in fat. And the final result can look fairly much the same as the original implant, but without the implant in, because the volume is similar. And we've developed a lot of techniques now across the world to try and use fat grafting as first of all, fat grafting is an alternative to breast augmentation, but to an adjunct to implant removal, for example, if you take the implants out. And a lot of people are surprised, a lot of women are quite surprised that when the implant comes out, it's like taking the weight off a spring, heavy spring. The back breast actually springs back up under elasticity. And so the shape is not too bad a lot of the time. And the third thing in that gamut as to whether we need to do a lift or mastopexy or not in the scheme of things. So we can just remove the implant, we can remove the implant in fat graft, or we can remove the implant and perform a mastopexy. So in Australia, when a woman comes to see me for a breast implant removal, they want all the implant out, they want the capsule out, and they want it taken out in one go. That's called en bloc. Now, that's something which is promoted in social media as the holy grail of breast implant removal, but in most cases it's not possible.
It's not.
The reason for that is that when we're taking the implant out, with the first Silastic 1 and Silastic 2 implants, the implants leaked a lot and there's a lot of inflammatory reaction around the implant, and so there's a very hard, dense capsule. And it's very easy to make an incision and just take all of that capsule and the implant out in one go. That's called en bloc. The problem with implants nowadays, it's not a problem, it's a benefit and a godsend really, is the capsule is so thin. The capsule is like tissue paper, which is around the implant. The capsule being the biofilm, which has got fibrous tissue in the implants. The capsule is keeping the implant away from your body. So the capsule surrounds the implant. The problem is that the capsule is like wet tissue paper, and when you lift it up, it tears. And if you try and do that en bloc on every occasion, what happens is if the implant is ruptured, it tears posteriorly, and then the gel spills upwards into the body, which is actually a disadvantage. So in most cases, you've got to actually make an incision, sucking the gel out, and then doing capsulectomy without. It's easier to do en bloc of the capsule once the implant is out. Because if you try and do an en bloc with the implant in, you always rupture the posterior capsule. So there's quite a lot of discussion about this at the British Society meeting just a few months ago that I was in London with, and one of the guys there who does about as many breast augments as I do said he's already had 4 ruptured, 4 pneumothoraces, 4 collapsed lungs from doing breast implant removal this year alone. Because when you look at the capsule, it's densely adhered to the pleura and the periosteum, and so when you try and cut it off the periosteum, women have prolonged pain and discomfort because of the inflammation in the periosteum, but there's a very thin layer between the posterior part of the capsule and the front of the pleura, and it's very easy to cut through that and create a hole in the lung. So the problem is that when people are asking for en bloc capsulectomy, they don't really know what they're asking for, because the problem is if you get a posterior capsular hole and there's always a lot of bleeding when you take an implant out because the capsule is adherent to the posterior muscle. If that blood fills up the space where the implant was and then it goes through that hole into the lung, there'll be a permanent reduction in your ability to breathe because you have a hemopneumothorax and a hematoma. So having a hole in your lung with bleeding in the cavity, it's not such a good thing.
Yeah.
So you don't need to be it's not a good idea to be super aggressive and get in a situation where you're going to create that pneumothorax. You're better off, in a lot of cases, taking the implant out, sucking the gel out, doing en bloc removal of the capsule.
Yeah.
There's a guy in New York who is doing en bloc capsulectomies, and he's making an incision right across here and then a vertical incision into the axilla and lifting hold of the side of the breast up. And that way he can do a posterior en bloc capsulectomy, but now women are having scars from here right up to the axilla. I can't see the point of that for a cosmetic surgery procedure for something which is a benign problem, benign lesion.
Now, for the family physicians like myself, a patient comes to me now and says, okay, doctor, I've got a sore breast, and they had augmentation at some point in their life. What reassurance, what advice can you give to the family physicians? Now we'll be faced by this, they come, okay, I'm sorry here, I'm sorry, you examine there. Of course, we don't feel anything. Well, how can we reassure them ourselves? We are on the other end of the street.
Well, first of all, breast implants don't cause pain.
Yeah.
And most of the pain in the breast is probably from mastitis or fibrocystic disease. The reason one might have pain from breast implants is if you had swelling from trauma, or there's an inflammatory process around the implant, or if there's a dense capsule forming around the implant. So again, the capsule is the thin biofilm which can thicken up because biofilm is a result of bacterial contamination of the implant during insertion. Now if that thickens right up, that can create an inflammatory process and that can cause pain. So that can be a dense capsule, and you'd notice that because the breast may be hard on one side, and if you get a capsule, that's going to cause the implant to elevate and tighten, sit up higher than the other side, so you may have breast asymmetry. And then if you have swelling in that breast, then now all of a sudden the ears are pricking up because we're concerned about ALCL. So the first thing to do in that situation would be to do an ultrasound of the breast to see if the implants are intact. Because if you have a ruptured implant, it's probably more likely to develop a capsule, in my experience with implant rupture. But it might also pay to have a look at the breast parenchyma as well during that situation to see whether there's an inflammatory cyst which is causing the pain. If there's no conclusion, it may be worth undertaking an MRI scan of the breast, and then we can look exactly at the nature of the capsule. And if you've got ALCL, an MRI will be able to see if there's a mass related to the breast, to the capsule. But the causes of pain with breast augmentation, usually it's an inflammatory process. It's interesting actually that I had a lady this week with this problem, and she's had her breast implants in for 7 or 8 years, and she's developed pain in her breast, and her breast has gone a bit firmer, and she's just been to the dentist in the last 3 or 4 months. And I think there's pretty clear evidence now that if you go to the dentist and you have breast implants, it's the same as having a heart valve. You'll get a bacteremia. That bacteremia can lodge on the implant, and that can be the catalyst for the causation of a dense capsular contracture. So from a primary care physician's point of view, it may be wise to suggest to the patient that they have a amoxil or some antibiotic prophylaxis prior to a dental work.
That's good. That's all right. Well, you got so much. Obviously, that's your area here. I mean, I can see that's your passion, anyway.
Yes,
that's right. I think anything else you want to tell us? Anything coming up of the horizon in terms of breast implant and complications, controversies?
I think Australia is leading the way in control of the implant, making sure things are not going wrong for our patients. And so the Australian Therapeutic Good Association have taken off implants which have been demonstrated now to have a higher association with anaplastic large cell lymphoma. And I think now Allergan Biocell has come off the market, some polyurethanes and some urosilicon and some Nagor products, so that there's the implants which are most highly textured have come off, leaving a whole group of minimally textured, micro-textured and smooth implants, but they're still on the watch list from the Australian TGA. So we'll just see over the next, moratorium goes for the next 9 to 10 months, and we'll be able to see if there's any further data collection relating to causation of ALCL with these smoother and micro-textured implants.
Yeah, the problem with that though is it doesn't happen short, it's a long-term complication. It's like years after surgery, then these things come up.
But a lot of these patients have had implants already in for years, and so we'll be able to see the end product of having augmentation for the last 20 years. So it's not necessarily a prospective trial, but we'll be able to collect data relating to what's happening right now. But I think that's all pretty clearly defined. That's pretty easy to define. What's not easy to define is the whole concept of breast implant illness and what that means, and whether should we actually be putting breast implants in anyway because of these other issues. And I think that's what's going to happen over the next 5 to 10 years.
You were talking about the fat grafting anyway.
Yes.
But how long does that last? Fat grafting, because again, it dissipates in the body anyway. The normal physiology takes over. And again, you lose that outlook you're looking for, feminine outlook.
I think fat grafting is a great asset and a great advance for plastic surgery. And it's been used, first with a Coleman used it in the face, and now Dan Del Vecchio in New York, was, to quote him, he likes to keep the capsule in there and fat graft the anterior breast. But we have a little problem in Australia is that when the implant's removed, to get an Australian item number, we have to remove at least half the capsule. And in my practice, I always remove all of the capsule because that's what the patient wants, unless I'm going to get a pneumothorax. But Dan's thinking is that if the capsule is left there and you fat graft the breast, the fat's not going to dissipate into the breast because it acts as a barrier. And his thinking is that the fat graft may last a little longer because it's not dissipating in, and eventually the capsule is a response to the implant being there. So once the implant is removed, then there have been studies now to show that the implant capsule will also go, and dissipate over time. So the whole thinking and concept of whether we should take the capsule out or whether we should leave the capsule there is changing, and it's a state of flux. On social media, everybody wants a capsule out, but you have these leading lights in New York and Los Angeles who are now saying, well, we're going to keep the capsule there because it's going to go anyway, and it's going to help us with our fat grafting. So fat grafting, very important. We harvest the fat from the buttock. It's the same concept as the Brazilian butt lift, so we're volumising the space. So what happens is the fat goes in, we volumise the space, and the fat acts as a spacer. So around the fat, new blood vessels form and fibroblasts create a matrix. And even if the fat resolves, the volume is going to be made up of that capillary and fibrin matrix. And you can have matrix there without any fat at all, and that is going to create volume. Some of the fat will survive. Some neo-fat cells, some progenitor cells will make new fat, so new fat will grow. And so you'll have some fat being absorbed, but a space effect, some fat staying there, and new fat being made. And so we can get more stable volumisation like that with fat grafting.
Okay, that's good. That's fantastic. That's good. Well, it's really a pleasure having you on the show, Dr. Vucak. Thank you so much for the opportunity. And for everybody else watching on the Doc Dev Show, we appreciate you joining us. It has been a deep language here. It's unfortunate we are doctors. There are sometimes we just have to explain some things in the way they are. We don't have a similar way of explaining things anyway. Don't panic. This show is basically for information sharing. It's for educational purposes. We're not here to scare anybody. If you had a procedure in the past, then be assured, see your doctor if you're really concerned about anything else we talked about here. But here we're just sharing information, and health professionals here, we just stimulate discussion, basically. That's what it is. So until we join again on the Tech Dev Show, keep well, keep safe, and God bless you, and bye-bye for now.